critical thinking and coding tips for Chapter 4.
Okay, our first question, what is the importance of non-essential modifiers in the alphabetic index if they have no effect on the main term in our code and do not change the code? Well, the answer is non-essential modifiers can help a coder choose the correct code. Sometimes a physician will document a specific type of disease, but there is no exact code to classify that disease. This is when the non-essential modifiers will be very informative. The coder can look for a term in parentheses that might describe what the physician has documented. Next question. What does a coder do if he or she cannot find a certain diagnosis in the alphabetic index? Well, our answer is, as a last resort, when a coder cannot find a specific disease in the alphabetic index, it's important to think broader and vaguer. Look under the key term of disease or disorder when all else fails. From that point, refer to the subterms below the disease and or disorder that describe the body site or organ. And, of course, then refer to the code in the tabular list to see if the code is an appropriate one to describe the disease and or disorder, or if there is another code in the same section that might classify the disease more accurately. Next, what is the relationship between coding guidelines and coding assignment? Well, the coding guidelines must be stringently followed under all circumstances. There is no room to take chances by manipulating the guidelines in any way. A coder should be able to review a chart that he or she has coded 6 months ago, and although he or she will not remember the exact code used, the coder should be able to see what coding guidelines were followed, since those same guidelines are followed with every record coded. Okay, here are a few coding tips for the information discussed in this chapter. It's important to review the ER record and the first day of progress notes as well as the discharge summary to determine the principal diagnosis. In some instances, physicians may choose what they think is the principal diagnosis, but in actuality, it may not meet the definition of principal diagnosis. Sometimes the principal diagnosis is treated, but another diagnosis develops during the stay. The physician may choose the incorrect diagnosis as the principal diagnosis because he or she may not have viewed it as the primary diagnosis that required the most hospital resources versus the condition after study found to be chiefly responsible for occasioning the admission to the hospital. Okay, in certain cases, some parts of the record are not significant in coding. And examples of this would be negative chest x-rays will have no findings to question. However, an infiltrate found on a chest x-ray and a patient being given antibiotics may summon a query by the physician to determine whether the patient has pneumonia. A positive urine culture may persuade a coder to query whether a patient has a UTI. However, if the culture was contaminated, the results are negative. According to OGCR, signs and symptoms that might be integral in a specific diagnosis are not coded.